Thanks, Kato, for kind introduction, and thanks the organization committee to allow me here to share my work in the coronary heart disease and the ubiquitination. Unfortunately, our session is running late for at least 10 minutes, but the good news is I'm the last speaker, so I'll give a short speak and we can finish the session in time. All right, so coronary heart disease is an age-dependent progressive disease in which a virus of the risk factor involved in its occurrence and development, and like we have mentioned, inflammation and also lipid accumulation. So, and in these recent years, recently people think ubiquitination may be involved and maybe play an important role in the disease development. And ubiquitin is a big family of conserved protein that we can see in the circle for the ubiquitin, so enzymes for E1. Yeah, where is E1 activating enzyme, and then E2 conjugating enzyme, and then E3 the ligase, so to catalyze the formation of the ubiquitin chain. And usually different ubiquitination at different ubiquitin sites may lead to different results. For example, as we know, K48, that means ubiquitination on the lysine 48 in ubiquitin leads to a protein degradation, and or like K63 usually lead to like inflammatory activation and DNA repair and other process. And on the other hand, deubiquitination, that means the deubiquinase that dissociate ubiquitin from substrate protein. And in humans, this kind of ubiquitinase, or we say DUB, is consists of 6 different families, and we can see the length of the ubiquitin refers to the protein size. And first of all, let me introduce ubiquitination in coronary heart disease, focusing on HIPO-YAP pathway. HIPO pathway is also a conserved protein family and control the cell and tissue size and differentiation. So, so it's involved in a lot of different biological, or say physiological or pathophysiological functions, like organ development, including cardiovascular development and hypertrophy, and apoptosis and autophagy and others. And it's reported that inflammation activated by YAP pathway play an important role in the inflammation of cardiovascular endothelial cells, and which can accelerate the progress of coronary heart disease. So, so in this way, so the YAP, also we say the inflammation also already become a potential therapeutic target in cardiovascular disease treatment, although sometimes with significant side effects. And here we are working on the YAP. So when we are considering about talking about inflammation, besides endothelial cell, we also ask how about the one of the most important inflammatory cells, that's the macrophage. What's the macrophage role in this progress? So we detect the YAP in the atherosclerotic model, and we can find as the disease proceeding, and when time goes on, we can see more and more YAP in the macrophage expressed. And also we can see this is from the mouse model. We can see different proteins, and this is YAP. We can have more and more YAP in tissue, especially in the CD6A that macrophage, and we merge see the yellow mark here. And so we generate a transgenic YAP transgenic mouse, and we can find overexpression of YAP really accelerates the disease progress. You can see after expression, we have the enlarged plaque, and we have more lipid accumulation, and we have more inflammatory cells, and also with destructive structure of the collagen contents. So when we treat a cell with macrophage with inflammatory factors like interleukin-1 beta, we found interleukin-1 beta can induce YAP expression in macrophage, and it's associated with the macrophage the adhesion and the migration. And the cell culture shows that overexpression of YAP can enhance migration of macrophage, and also we can see interleukin-1 beta can activate a YAP, but there's no change in YAP messenger RNA level, and also the upstream signaling pathway of YAP. I mean like LRAS and the MST, no change, which also indicate it's possible that the effect of interleukin-1 beta on the expression of YAP is the post-translational modification of protein rather than transcriptional or other. So if so, we can also see the YAP interleukin-1 beta effect on YAP is similar to MG132, the proteasome inhibitor. Although what that happens, so the pathway of interleukin-1 beta is already studied very well, and we know each step in the pathway. But what happened to YAP? How interleukin-1 beta regulates YAP expression? So as easy way is to, we know that the downstream of interleukin-1 beta is like MYD88, like IRAK1 and TREF6, TAC1. This is classic pathway, and we can inhibit each of the molecule. So if any molecule inhibits, and then we can find the interleukin-1 beta is no more able to induce YAP expression. That means this molecule is important in the pathway. So we can see when we inhibit, when they silenced MYD88 and RAK1 and TREF6, and in all these we can say that the interleukin-1 beta failed to induce YAP, which means these proteins important in this pathway. But if we inhibit ITAC, we can see the YAP is still inducible by interleukin-1 beta, which means between TREF6 and TAC1 is an important corner that is after the signal go to the TREF6, it's no longer heading toward TAC1 but to a new path that is to the YAP. So what happened to the ubiquitination of the YAP? We use mass spec to detect the ubiquitination site, and we found it's cases 3 ubiquitination of ubiquitin. That means it goes to not really for degradation, but for the function modification. And also the site on the YAP protein is K252. And the immunoprecipitation and the dual link study also confirmed the direct binding of TREF6 and the YAP protein. And also in patient sample, we also confirmed that instead the YAP expression in the plaque in STEMI patients is really higher, significantly higher than in control, and also positively correlated with the interleukin-1 beta level in patient serum. So here we get the first conclusion that is interleukin-1 beta can activate the YAP and accelerate the progress of the coronary heart disease, also in atherosclerosis. So on the other hand, how about the deubiquitination? So deubiquitination is we use a DUB siRNA library to screen the DUB that may alter lipid communication in macrophage, and in this way we can find some difference. That is, we found a number of different DUBs that if we knock them down, the macrophage take more lipids, or they take more LDL, and especially for OTUD4, USP9X, USP39, and USP24. And then we validated it in a human sample, and also we found only USP9X decrease in severe lesion from human plaque. And also for similar thing, we also didn't see any change in the messenger RNA, which means it may happen same thing or similar thing to YAP, that is a post-translational modification. So we can see, with the mouse model, when the disease is proceeding, we can see there are more and more the green, the C636, the macrophage, but the USP9X is gone. And also in human plaque, it also happens. We can see in the mild lesion, we can see some red USP9X, but in the severe lesion, it's gone. So in this way, we also generate a USP9X specific macrophage specific knockout USP9X model, and we can see severe lesion. And also we can see, similar to the previous study, we can see enlarged plaque, and we can see more lipid accumulation and destroyed collagen fibers, and also more macrophages. So since it affects the lipid communication, so we think either the cell uptake more lipids, or it effects more. The effect study shows some difference. So we think about what happened to the cholesterol LDL receptors. Unfortunately, when we do the Western blot, we didn't find any change. That means no difference between some major carbohydrate receptors like C36, like RA1, B1, no difference. So what happened to this? When we have no idea, we use omics. So we use ubiquitination to try to find out the substrate protein of USP9X. Very lucky, we found the old friend here, SRA1. SRA1 is supposed to be one of the most important LDL receptor on the macrophage membrane, and so we are working on SRA1, and then we found it's true that USP9X can remove the SRA1 ubiquitination. It removes the K63 ubiquitination and lead to SRA1 activity change. And also we can see the K63 ubiquitination was located on the bind to the SRA1 K27. Since there is no protein content change in SRA1, what happened to SRA1 to make it uptake more lipids? So actually, it's a difference in the SRA1 internalization. So we have another model that is in the healthy people. When the SRA1 is trying to uptake lipids, the LDL bind to the SRA1, then it starts the internalization. At this time, a KCD3 ubiquitination helps the internalization of SRA1. And this time, what happened? USP9 comes. It comes and destroys ubiquitin chain, and in this way, SRA1 failed to go to the translocate to the cytosol, and also the LDL is also remained on the membrane, on the cell membrane. But in patients, if there's something like inflammation or other drug or something else risk factor happens, it inhibits UBE9X. At this time, nothing to inhibit, nothing to stop the internalization of SRA1, and which means to more SRA1 as well as LDL was uptake to the cell and lead to a formation of a form cell. So based on the previous two study, we found that the ubiquitination do harm to the heart and vessel, but deubiquitination seems play as a protective. But is this to always play the thing in this way? Not really. And if you remember that this previous figure that is when we screen DUB for the macrophage lipid uptake, not only see we have this side significance molecule, also we can see something here. This is that although we do find some knockdown of some DUB, they really speed up the uptake of the lipids. We also find some knockdown can reduce the lipid uptake, which means some DUB do harm to our macrophage, and it may lead to acceleration of the formation of form cell. So the same thing, this is the ongoing study, and I will go through it very in brief. So with same technique, we also screen DUB in macrophage and see if we'll change the uptake of LDL. And we found the two significant DUB is DUB 17 and D 48. And when we do cell culture to test if it can really change the lipid accumulation, we found the 40x, yes, it changed, and it may do harm to our macrophage cell. And here, and then we also the same way we knock out the 48, and we found the lesion is significantly improved. And we can see the plaque is reduced and the lipid accumulation reduced, and also the inflammatory cell reduced, and the collagen looks better. So what happened to C48? With the same technique, we also find substrate protein. So it's also our good friend, and also similar to SRA1, but not SRA1, CD36. It's another family member of that is one of the important cholesterol receptor on macrophage. And it's also a kind of CD3 ubiquitination of C36, and the UT47 is able to remove the ubiquitination of C36. And also we can see the 48 regulates C30 plasma memory enrichment. And besides, we also find interesting that is C36 is able to bind to the cytoskeletal protein, flamin B beta, in which we have so you assume that the story is about then when CD36 is in the cytosol, it binds to SRA1 and help also when connecting to the flamin B beta. Flamin B beta is skeletal, so it's like elevator. So it quickly transport CD36 from the cytosol to the membrane, which can accelerate the circulation of CD36 and also thus speed up the lipid uptake or the lipid coagulation in the macrophage, and then lead to the formation of form cell. So from this study, we can make conclusion. The first one is protein ubiquitination and deubiquitination are deeply involved in the atherosclerosis. And the second, different ubiquitination substrate protein and different ubiquitination type results in different biological and pathological effects, also to different effects on the progression of disease. And certainly, ubiquitination and deubiquitination of different proteins generates a huge regulatory network in atherosclerosis, in which potential therapeutic targets may be revealed. So this study is supported by my by my colleagues, Dr. Du Jie from Anzhen Hospital, Dr. Yi Zhu and Dr. Ding Ai from Tianjin Medical University, and Dr. Yihai Cao from Karolinska Institute, and also thanks to my two fundings. So that's it. I'm happy to take questions.